Welcome everyone to our September Grand Rounds. My name is Marielle and I will be your host for today. Before we start, I'd like to go over a few things. This presentation will be recorded and uploaded to our YouTube channel and also Dr. Hruby's Figure One account. If you wish to watch our videos on YouTube, there's an option of playback speed to adjust the speed of the video. Also in Zoom, you may turn on the feature called closed caption during the presentation to allow for subtitles. With that being said, I would like to hand it up to our medical director, Dr. Pecchia.
Thank you, Marielle. Appreciate it very much, and happy to be here once again as medical director of Global Offsite Care and Global Grand Rounds, and welcome to all of you, and appreciate your interest in today's topic, Sprained Ankle and Osteopathic View by Dr. Hruby, my colleague at Western University of Health Sciences, College of Osteopathic Medicine. And a little bit about Dr. Hruby, who graduated from the College of Osteopathic Medicine Surgery in Des Moines at Des Moines University in Iowa. He interned at the Osteopathic Hospital of Maine in Portland, Maine, and was professor and chair of the Department of Neuromuscular Medicine and Osteopathic Manual Medicine at Western University of Health Sciences College of Osteopathic Medicine in Pomona, California, from 1999 to 2009. He's retired now from that position, but continues his work at Western U as a professor and consultant to the Department of OMM and NMM. In this capacity, he's involved with teaching research, curriculum analysis and development, and mentoring of new faculty and of the pre-doctoral OMM fellows there. He's also involved with Western U's interprofessional education program. A fun fact about him is that he's an avid but frustrated yet accomplished jazz musician. Just ask him. So with that, before handing it off to Dr. Hruby, just a reminder that this will be recorded, including the Q&A session at the end, and posted for those who may like to review it asynchronously. Will also be posted on the website of our partner for advancing medical education in this space with Figure One. You'll see that on some of the documents and the invitation that was sent you, figureone.com. Feel free to take a look at that, both for our content as well as pertinent content that is also CME eligible at no cost to you, figureone.com. So with that, Dr. Hruby.
Thank you. Yeah, the musician thing is, I just want to be good enough to have somebody carry my amplifier. All right. Well, thanks and welcome everybody. Glad to be here with everybody again. First thing I'm going to do is gear up to start. So as Dr. Pecchia said, we want to talk about the sprained ankle, and I will say that this is not obviously an uncommon or rare problem, and I think a number of the things that are in the slides here are things that probably a lot of people are already familiar with. My real goal is to get to tell you a little bit about how osteopathic doctors may look at a sprained ankle and have some things to contribute, particularly in certain conditions that arise that may become chronic. So I'll go through the slides. I'm going to move along with some of them. There are a lot of anatomy and physiology, and I want us to just be familiar with it. So, but we'll just proceed right along. And if you have questions, we'll get to them. So my usual non-disclosure slide. And so what we're aiming for here is that we'll be able to make sure we understand exactly what a sprained ankle is, what kinds of sprains turn up, how we diagnose and treat them, and additionally, how we might look at them from an osteopathic point of view with some things that might not otherwise be considered or noted, and then apply that in the treatment. So this is a definition, and basically, there's lots of definitions. They're pretty much all similar. This one goes on to talk about basically it's a ligamentous injury, and depending on the severity of the injury at the time, kind of determines a little bit how severe the ligamentous stretching or even tearing is, and whether anything else is involved. And usually, this goes a little bit beyond that by talking about common ways that it gets sprained, to sports injuries, stepping off of things in an awkward fashion, that type of thing. So it's just a standard definition, so we know what we mean. And some of the facts, it's, the fair number of injuries. Any of us there, if you're interested in sports at all, particularly, well, it doesn't matter which one. Here in the U.S., I'd say if you're a U.S. football fan, basketball fan, baseball fan, plenty of ankle injuries in those sports all the time. And it's usually an inversion injury, meaning that the foot somehow has turned inward, and usually plantar flexed a little bit too. That's the most common kind of thing that we see. And the anterior talofibular ligament, usually the most frequently injured ligament. It is said to be the weakest ligament of all the many ligaments that are around the ankle. And they occur in, fully mature athletes at that area. And this is a very brief point, but yes, it's most commonly you can palpate over that area and get a pretty good idea that you have a sprained ankle. And this anterior drawer sign, we'll see that a little bit later in the presentation. Lots of risk factors. These are kind of good to keep in mind when you're faced with a patient who has an injured ankle. It's worth it to get some idea of their lifestyle and other things, so that you have an idea if they are at risk in the first place for ankle sprain. So this would help you, obviously, to not only in the treatment of the problem at hand, but to be able to recognize and perhaps help educate the patient on these risk factors, so that as they're healing from their current ankle sprain, they can make some plans to avoid some of the risk factors so that they don't get recurrent problems. So there's a whole string of these that go on along in here. If they are involved down here at the last point with sports activities, again, there are strategies that they can take with, proper gear and things like that. Although by definition in sports, you are at higher risk for these things. Again, the anatomy, we'll just take a look at these slides just to be familiar with what we're talking about. Obviously the formation of the area that we're talking about, distal tibia and fibula, form what we call the roof of the ankle joint, or the mortise. The talus fits into this area. And the foot is supported by a lot of ligaments, but the ones that we're mostly interested in with respect to ankle sprain because of the frequencies are the anterior talofibular, the calcaneofibular is the next one that's usually injured, and sometimes the posterior. The big ligament of interest on the medial side of the foot is the deltoid ligament, which is not commonly, but it can be injured. The reason being when the foot inverts, rolls in, it's really the lateral ligaments that are put on the most stress. There can be eversion injuries to the ankle, but they're a little less common. So again, just to make us familiar with the area of the bones, we can see this is our basic anatomy of the foot, and we see we're going to be of mostly interest in this area, particularly the calcaneus, the talus, and somewhat with the lower tibia and fibula through here. And again, just a medial view of the same foot, just to get us familiar with the anatomy once again. And I've got like every possible view of the foot here, I guess, but in case you're interested, or in case you're getting ready to appear on Jeopardy, and this is going to be one of the categories. So again, just to show us the lay of the land here in terms of the bony structures. Some other forms, when we get to the osteopathic discussion, we're interested in this calcaneus, the talar, the talus. A couple other important areas in here are the navicular and the cuboid that are sometimes involved in certain ways that can be dealt with osteopathic treatment and can help speed along some recoveries. So lots of muscles. I'm just going to show you they're here. We have the lower extremity down there conveniently divided into 3 compartments, and these muscles, as you see listed here, belonging to each of the compartments. So again, just to make us familiar with all the structures that are involved through this area. Here is this anterior compartment with the major muscles coming down through here: tibialis, extensor hallucis, and the extensor digitorum, and the posterior compartment. And, this is of interest in that you can get a sprained ankle. You can also get some injuries down here through the gastroc and soleus and the Achilles tendon areas as well. Our posterior compartment, just to be complete about what's going on here. Here we see those other muscles that we saw in the in the other compartment coming down here and going out under the foot towards the toes. And again, this is the other part of the lower end of the posterior compartment where some of the muscles attach into the foot down in here. And this really is just another view of the same thing. So you can see the fibularis longus and the brevis. These 2 muscles, they're we don't think of them a lot, but they're in there. And here we show how this one is going to actually come down the lateral side and cross under the plantar surface of the foot over to the first metatarsal area, and the brevis actually staying on this side and attaching to the 5th metatarsal down here. Peroneus muscles similarly. So the point is that when you sprain an ankle, we get particularly concerned because it's typically a very ligamentous type of sprain or injury, but don't forget that the muscles are stretched and strained too, and get involved with this. And again, our ligaments here on the medial side, here's our anterior talofibular ligament, the calcaneal ligament, and there's the posterior one here. Those are the ones that I mentioned in a few slides ago. Whoops, I'm sorry, didn't mean to move quite that fast away from you. And you can see there are just lots and lots of ligamentous structures through the ankle, which makes sense. But typically, this is the area where we're going to have our involvement with the ankle sprain. And from the medial side, just to remind us of this large deltoid ligament that could be injured, particularly if you get one of the less common eversion injuries. And just one view posterior, I was just trying to be sort of complete there to have all the views of the area. Again, just get a vision of the anatomy in our minds that we're dealing with here. So all these other ligamentous structures helping to hold this whole joint structure together. The nerves involved here, branches of the sciatic nerve, branches into the tibial and the common peroneal nerve, and then further splits to take further innervation further down into the lower extremity and the foot and ankle area and that type of thing. So, and just a diagram to show you, again, the innervation down into the foot and ankle. This is important in the sense that just not only recognizing the anatomy, but we'll see a little bit later from the osteopathic point of view, when the ankle gets injured, there are also sort of mechanical problems that can go along with it up through the tibia, the fibula, and on up into the pelvis area. And so these nerves can be involved from as far up as there. Again, another view with our 2 major branches of the sciatic nerve there. So, and I think we're also familiar with the idea that they usually are considered as a grade 1, 2, or 3 level, depending on the amount of injury that's occurred. Again, most common anterior talofibular, and secondly calcaneofibular. Posterior one is rare, but it could get injured. So And the common mechanism of injury here is it occurs when the foot rolls in and you get inversion and a plantar flexion when the actual trauma force hits that area. Grade 1 is just small percentage of the fibers. There's not a lot of, there's pain on motion, tenderness, a little bit of swelling. And again, it's just increasing levels of more fibers that are injured and more pain, tenderness. Instability starts to come into play here. And then when there's a complete disruption of the ligament, you have obviously a lot of pain, a lot of tenderness and swelling and joint instability, and probably not able to weight bear at that point too. A little bit more precise grading that I saw here. No real loss of function in a grade 1. There's no ligamentous laxity, and if you will, though the drawer test that I talked about, and I'll show you that, and Taylor tilt test will be still okay. Not much in the way of bleeding or hemorrhaging in the joint. No real point tenderness, and then the motion is small here. The motion decrease with this is small because of the injury. Grade 2, it's a little more, this series here is a little more objective sounding, more loss of function. These tests are going to be, the ATFL here with the anterior drawer test will be positive. This test will be negative for the calcaneal ligament. A little bit of hemorrhaging. You'll definitely have point tenderness and a little, an increase in the amount of, an increase in the amount of decrease in the motion in the ankle, and more swelling comparatively. And then finally, when we get a real severe problem, then we have positive tests here, hemorrhaging, a great deal of tenderness. There's a lot of loss of motion here, more swelling. And by this time, you're thinking about taking x-rays, and you're going to need those to see some of the help make the diagnosis as well. And these movements can be then measured on there a little bit. So that was just my reference for that information. Here's a picture of an inversion sprain taken from one of our textbooks, and you can see how the foot would be rolled in and somewhat plantar flexed here. And so here's our major ligaments. This would show you probably an injury just to the anterior talofibular ligament here, along here. Okay, so continuing along, and this is really the point to think about here to introduce kind of some of the osteopathic concepts about this. There are biomechanical restrictions from an injury like this that will affect the lower extremity on upward from the ankle up into the pelvis area. And some of the terminology that they're using here may or may not sound familiar to you, but here's our inversion sprain at the bottom here. And we're just talking about how we would consider the motion mechanics to be affected. The big things down here are the navicular and the cuboid can get involved. They will have a certain amount of movement physiologically, but they will be strained and possibly pushed or pulled beyond their joint range down in here and restricted in those positions. The talus, which helps primarily with the dorsiflexion and plantar flexion of the foot, with the foot being plantar flexed, the talus is going to glide, in odd directions. And one common area, although he talks about posterior lateral, it's with an inversion sprain, a lot of times the talus will be suddenly and abruptly pulled forward anteriorly, and it can become restricted in that slightly anterior position. And that's something that can be responsible for slower healing and a clinical situation where it appears to be a chronic tendency to ankle sprains in people. If you remember the anatomy, the fibula is attached down here. So when all that happens, the fibula is going to be pulled a little bit too, and it's going to be restricted here at its distal end and up here at its proximal end. It doesn't look like a big bone, but it's rather important in the mechanics of the lower extremity. So when all this injury happens and these bones get put in positions where they're unable to get back to their physiologic positions. It's very minor movement, but it can be very painful, and it can be very restricting into the biomechanics of the whole area. And even the tibia will glide a little bit more anterior than it should be up in here. The femoral area tends to rotate, which then has some effect on our nominate and sacroiliac mechanics. So we can have patients that they will definitely have low back pain along with all this kind of stuff. But what I'm getting at is, from an osteopathic point of view, after we treat the ankle in our usual fashions, if we're not attentive to any of these biomechanical restrictions, they can be things that just linger for patients a lot of times. The common thing here with the talus, I might as well just say it, is I've seen this a number of times clinically, that the talus gets pulled anteriorly and it's restricted like that. These are the patients that down the road, whether it's weeks, months, or even years later, these are oftentimes a patient that will come in and say, yes, I had a bad ankle injury, and I sprain my ankle, frequently sometimes, and they'll say, well, my doctor says I just have weak ankles, Well, the weak ankle is in part possibly because of this talus. We call it an anterior talus at that point. And if you really look at the patient and test them, you'll find that you can't dorsiflex their ankle. It's kind of like within normal range, but it's very restricted at the end range of that. And they don't have that quite full physiologic motion in that joint. And treating that joint can oftentimes get rid of people's weak ankle. So we'll show you that in a little bit. Differential diagnosis, common things. We want to be sure there's no fractures or avulsions, tendon subluxations, things like this, or Achilles ruptures. Okay, interosseous membrane tear. I take that to, in a way, mean a little with the interosseous membrane, just be concerned about what they call a high ankle sprain, which usually occurs down there at that lower tibia and fibula connection in that syndesmotic area of the membrane. Okay, so when I talk about, at least here in the U.S., our football players who are out with a high ankle sprain, that's what a high ankle sprain is. They've gotten hit with a rotational force, and it's caused a tear or an injury to that membranous area down there. We've already covered a little of this. Sprain, typical sprain, tenderness, swelling, a little bit of bleeding into the skin and areas there. And this is the typical injury that occurs if they, a lot of times people injure their leg and you don't see them for a day or two. So if it's been there or if it hasn't been treated at all for a couple of days and now you're seeing the patient, you may find some of these things that you wouldn't initially. Again, bruising, edema, difficulty bearing weight, tenderness on palpation. Okay. In a grade 1, you should have this normal subtalar movement. Sometimes they don't, but it should still be intact. And there can be some of these avulsion fractures. So you just need to be vigilant about it. But mostly in a grade 1, you won't get too much of that kind of stuff. So differentiating it from fracture, the obvious thought would be an X-ray. One of the, at least in my own clinical experience, one of the sort of downsides with an immediate X-ray is that there's a lot of swelling in the tissues and stuff. And in my experience over the years, it's been not unusual to have somebody right now injured their ankle and you see them very quickly. And if you X-ray them, the X-ray comes back and the radiologist, will tell you on the X-ray that they don't see any obvious fractures or anything, but they will also tell you that there's a lot of tissue swelling and edema, and that can blur some of the finer aspects of avulsions and other hairline type of fractures. And so they'll end up recommending a re-X-ray in a week or so to make sure of things. That's to the point where, everybody has their own approach, but in practice, if I saw somebody like that in the emergency room or actually really here in the United States, I think in the emergency room, you're probably going to practice more defensive medicine and go ahead and X-ray them. In my own practice, depending on the real condition of the patient. Oftentimes I didn't x-ray them at this point. I just went ahead and moved on with treatment. And then as in my follow-up visits with the patient after the ankle was no longer swollen, and if they're no longer swollen and they're improving, then that's fine and you're getting better. If they're still having a lot of symptoms, then that's a good time to x-ray them, where you get a much clearer picture of the tissues that are involved and make sure that there's really no fractures. And in some of the more other, lesser common instances of this, if it's still going on, not healing, you may need to resort to, CT or a bone scan more commonly to make sure that you don't have some more occult fracture, for example, going on. Plain x-rays is usually the common way. There are what they call the auto ankle rules to rule out fractures. So these were rules that were developed over time, and they're very good in helping you to make decisions about whether you really need x-rays or not. So I imagine most of us are familiar with these. I have a little bit of overkill here just to show you what they are. But basically, this is the summary of the ankle sprains. If you're wondering about x-ray, if there's bony tenderness at the posterior edge of the lateral malleolus, or at the posterior edge of the medial malleolus, or if there's inability to bear weight immediately after injury and later on when examined. Those are some of the boiled down key elements that you might really want to consider an x-ray if you haven't seen one already. You also need foot x-rays as well as ankle x-rays if you have tenderness at the base of the fifth metatarsal or tenderness at the navicular. So where you may have an injury or fracture to that area. And again, inability to weight there. And again, we're getting into a little bit of the treatment here, fractures. The treatment that we all know, rest, ice compression, elevation, early mobilization, if you can. People do need to kind of immobilize a little bit. They don't necessarily have to be placed in a brace or a cast right away unless they have but they will, just as soon as the initial treatment helps to relieve pain, reduce the swelling to where the patient can move the joint much. You want to try to get them started on, even if it's just plain practicing a little plantar and dorsal flexion to get mobilization into that ankle as it continues to heal right away. This is the anterior drawer test for that anterior talofibular ligament. We just simply grasp the lower extremity with one hand, the other hand cupped under the calcaneus here, and stabilizing the lower extremity here at the tibia and fibula, and moving the foot anteriorly in this way to see, is this joint stable or is it lax? Is it moving too far forward? It gives you the sign of the acute injury. The inversion test, or the Taylor tilt test as they call it, this is for that calcaneofibular ligament. Okay, so you should be able to invert the ankle, but if you can invert it more than 25 or 30 degrees, then it starts to make you suspicious about injury to that area. So all these taken in the context of having a patient with an acute injury in front of you, swelling and the pain and stuff may make it difficult to try to maneuver these things, but you attempt them at least anyway. You can also posteriorly glide the ankle. So you grasp the foot in this way. Take a look at this hold with the hands, because I'll remind you of it later for something else. But in this, you grasping the foot with the hands over the dorsal area of the foot with the thumbs here at this talar area. And basically what you're doing is just going, other than the anterior test before, we're doing a posterior test. We're pushing the joint backwards here. Okay? And I looked around. It was hard. I had a hard time finding what people appears to be. There's a lot of wonderment about what the exact normal is. It should be what they say 20 degrees. It should be, in other words, posteriorly and trying to dorsiflex it a little bit. Okay. So, but the basic idea is testing the ligament. Does it feel like a firm ligamentous structure, or does it feel like it's been injured and it's lax in some form? But basically, if you think of these Ottawa rules, and basically it gives you the regions here that you could divide the joint. And They're talking about tenderness in these areas as talking about here. So here's the posterior end of the malleolus here, the navicular bone over here. So the medial and lateral, the posterior edges of the medial and lateral malleolus, the navicular bone, the base of the fifth metatarsal. If you have point tenderness in those areas, that's a legitimate reason for X-ray rather than waiting. You can see it a little bit similarly, and maybe easier here, gives you sort of a shaded area of each of these where you can consider the need for X-ray if you have that pain in those junctional areas. If you're interested, this was the literature source for all of that information. And again, I'm not going to repeat it's all for, but it's this thing that we've been talking about here, describing the tenderness in those regions. So again, we want to protect the joint, rested, ice, compression, elevation, and anything else depends on specific circumstances with the given presentation. But when I think about the osteopathic treatment, there have been authors in the profession. Dr. Blood felt that he saw this relationship with various other dysfunctions as we look at them in the body, including even up into the rib cage and thoracic area. And he wanted to recommend the treatment of all these other regions and the foot and ankle, as they all go together to restore all the mechanics that were going on beforehand, and it tends to produce a little bit faster response and clinical result. Though this point about the clinical trial, I think I have other information in here on it. Again, this is just to remind us of those osteopathic looking mechanical restrictions that can occur with this. So sprains are traumatically introduced. These restrictions, we call them somatic dysfunctions, with the biomechanical modifications that go with them. And if we don't diagnose those, they can prolong recovery time, we think. And this is just rehashing the inversion plantar flexion condition that it goes into producing some of these restrictions. We can develop pains, overstretching and trigger points in some of the muscles. The fibular head really is an important biomechanical thing, and so there has to be that little bit of motion that's at the distal and proximal heads really needs to be restored, along with the tibia up there at the knee joint. The research that I mentioned here in the other slides, this was a study where in the emergency room, 55 patients, adult patients, within 24 hours of the injury. So they had a control group and an OMT, osteopathic manipulative treatment group, evaluating people for edema, the range of motion, and pain. And they measured pain on a 1 to 10 visual analog scale, as we call it. There was really no difference in these measures in people at the baseline. However, after the treatment and the types of OMT they used, usually in acute injury, you don't use anything very forceful. So these were soft tissue and fascial directed techniques. Muscle energy, which is a gentle isometric type approach. Counterstrain, which is a technique to look for these trigger point areas in these areas. And basically, if they're there, even in an acute situation, you can gently find, oftentimes, if the trigger point is tender, you can begin to slowly position the foot to where you reduce the pain of the trigger point itself under your finger, and then simply hold the joint in that position, or in this case the lower extremity, for a period of time to allow some relaxation of the tissues to start engaging in that area. There are techniques to gently work the tissues to improve lymphatic drainage right away, and that type of thing. So you can see here their OMT treatment session was anywhere between 10 and 20 minutes with these techniques. They had objective measurements for these things. For example, they marked certain areas on the foot and ankle, measured the edema, for example, by measuring it with a tape measure, and that type of thing. And they can measure range of motion with goniometers and such. The point was that everybody received the usual standard care, including non-steroidal anti-inflammatories for pain and discomfort. Follow exam was done within the week. And after the one session, They had very statistically improved everything on the ankle. So they had a statistically significant improvement using OMT over and above the standard medication or standard medical treatment. So they all had improvement. They all had improvement in a week, but statistically significant improvement in the OMT group. So we have some research evidence to support this kind of thing. So we recommend, these are some of the areas that I've been talking about them all along here, but there are different techniques to approach all of these kinds of things. This is a counter-strain treatment right over the anterior ligament, the finger there, and then basically dorsiflexing and everting the foot to where the palpation of this point now shows a lot less tenderness. And it simply held there. Counter-strain would hold that for about 90 seconds or so. It sounds very simple and magical, but it's a very good technique for these kinds of things. And again, this is just describing that counter-strain technique for you. So you really need a dynamic picture here, but basically grasping the foot here with this hand, and this other hand just moving up and down slowly along the lower extremity and making sure that we take all the hypertension and our hypertonicity and swelling out of any of these muscular tissues around here, the muscles and all the myofascial tissues in the ankle and lower extremity area. So when do they go back, to normal activity? Well, when the ankle isn't tender, or when the strength is equal and the patient can stand, and not just stand, but can they stand with their eyes closed, and if they can balance on that injured side for 30 seconds without pain or discomfort, then they're in pretty good shape just to go back to, start going back to their function. It usually takes, up to a couple of weeks to really start going back, making sure all this is ready. But that's the general kind of structure with things. And again, another reference for this. And these are my other references for it. And there we go. Thank you. That's the end of as I like to say, that's all the damage I can do to you at this point. So,
Right. Thank you so much. Really appreciate it, Dr. Hruby. And we've got a couple of minutes for questions. As you're thinking about those, I have one specific to, as you may know, pertinent to our global offsite care partners, many of whom are practicing medicine in austere circumstances, to say the least, and very often have nothing more than a roof over their heads called the clinic. And individuals who come from remote areas and present to those clinic environments, sometimes with handheld ultrasound, thanks to individuals like Mary Graves. Thank you for being here today, Mary. And,
I saw her name on the thing.
Yeah, an example of supplying handheld ultrasound to a clinic like that, in this case, the Bermudas. And so as the technology advances for looking at handheld ultrasound as an imaging center per se, it turns out that using handheld ultrasound for initial assessment of ankle injuries can actually be done. Doesn't totally supplant X-ray or CT scan, but can give us an estimate of an ankle injury, not only the ligamentous issues that may have ensued from the injury and the swelling, of course, hematoma formation, but also cortical irregularities, cracks in the surface of those ankle bones to varying degrees. So, that would be definitely a real plus. It's easy, let's say here or lots of other places where you have facilities fairly readily available. That's why I say that my decision sometimes clinically was not necessarily an X-ray right away because of all the swelling and stuff. But I could get an X-ray anytime, if I changed my mind. And you're right. And even without that sort of urgent sound to it, your ultrasound, it may not be the best replacement for those things, but it will give you a pretty good picture too, and give you much more information to decide how you want to proceed. There's no doubt. Right. So we had a practitioner who assessed an ankle, used ultrasound to rule out an obvious fracture, and followed some of the acute care rules, but then saw the patient in follow-up, maybe using telemedicine. What modalities, what could that practitioner use to gain some competency in some of the techniques that how could they educate themselves, get some practice about how to do these techniques?
There are, yeah, that's a good question, and I think that it sparks a lot of discussion, at least in my circles, because it's a hands-on kind of thing, and it's like, well, can you really teach people how to do manipulative treatment by video? Particularly if they have not ever been trained in any this kind of palpation or looking for these kind of things. And I think in a way not, but what do you do in these situations where there's not much resource? So I'd say you need to be cautious and careful. But I don't have offhand a quick version to refer you to. But I know that if you go on the web and places like YouTube and stuff, there are some osteopathic doctors, and you can go on the web and just literally Google osteopathic treatment for ankle sprain, and you're going to get some of these videos where perfectly good DOs have gone on and just did a video to show what they do. And so you can get some insight that way. It's a little vicarious, but at the same time, it can be very informative in the circumstances that you have. So somebody had a question. I saw a hand someplace.
We have another question, Mary Graves. She said, do you recommend ankle replacement in the severe traumatic arthritis? In the case of severe traumatic arthritis? Oh,
I see. Well, I have to say I don't have a lot of experience with that. Although, well, it's gonna depend. Traumatic arthritis, it can get to the point where if you have that loss of motion and then eventually instability. When you get that instability, then there may be that it may be the final choice that they need to have a joint replacement. I think it's just going to be dictated by those kinds of situations more than anything else. So if it's really that dysfunctional in an otherwise healthy patient, that might be the necessary thing to do.
Thank you. Hey, is age a factor?
Well, I don't know. I'm not a surgeon, but I would think that you have to consider that, but I have treated people, I would say, and right now I'm thinking, treating people with not necessarily traumatic problems, but people that had like arthritis, people with rheumatoid arthritis, people who had ankle replacements, had wrist joint replacements and things like that. I've treated them. And some of those people have been, usually with rheumatoid, I wouldn't say usually, but or even osteoarthritis. These are older patients, but they seem to be pretty tolerable to the surgery that they had.
Thank you so much.
Another quick question on treatment is there a role post-acute injury for non-surgical injection treatments like sclerotherapy, which I know is used in other types of joint injuries? So what about that?
I think that is, I guess I'm going to say the short answer in my mind is yes, there is a role for that. And I think you have to observe and see how things are happening. But as people heal up from this, if it's clear that they have a residual laxity in those ligaments that's going to be contributing to the instability in there, then that type of sclerotherapy or prolotherapy, as a lot of people call it, can be very helpful to people. They can help to, as I understand it, it's not a scarring so much as that prolotherapy is something that actually proliferates some new cellular development in there. So if there's a residual laxity that's really unable to get stronger by other conservative methods, that can be a helpful thing.
Well, if we have no further questions, all right. Well, thank you again so much, Dr. Hruby. I really appreciate your time and interest and experience and perspective. Another reminder, take a look at figure1.com for all of you here today, and also to share availability of this recording and others, as well as the extensive collection of CME eligible content. I looked up ankle injury on figure 1 while we were enjoying the talk, and there's plenty there, quite a few cases that you may find interesting, very much pertinent to this topic. So with that, I will hand it back to you, Marielle.
All right. Thank you, Dr. Hruby, for this very informative presentation. Just a reminder that this recording will be uploaded to our YouTube channel within a couple days. And also, please use the link to Figure 1 to register. If interested, there's also a link to sign up to receive our monthly Global Ground Rounds. And with that said, our next Global Ground Rounds will be on October 9th. And there's a question about accessing the document. I will have it linked on our website, so you can access it there. And as always, we appreciate your continued interest and your participation. Thank you, and have a great rest of your day.